Well, hello, welcome. My name is Linda Prezioso. I'm a nurse practitioner at Rocky Mount Family Medical Center. This is Here's to Your Good Health, which is a program by you, for you, and about you, sponsored by WHIG TV. Tonight we have Dr. Karen Szymanski.
Hi.
And Dr. Ronald Pope. They are, I believe, the newest surgeons to come to the Boyce Willis Clinic. And they kind of work together. Dr. Pope is a surgeon, and Dr. Szymanski is too, but she practices plastic surgery. So, and they work together as far as breast cancer, reconstructive surgery, and all that. So we're going to talk about those things tonight. I'm very excited. We've talked back and forth with Karen a lot to get her on TV, and so here we are. So welcome, you two.
Thank you.
So nice to have you with us. So nice for you to be in Rocky Mount with us. That's great. How long have y'all been here now?
We moved a little over a year and a half ago.
Yeah, I thought it was, I figured it was maybe about a year when you were at my office and
Yes.
you came to visit. So, so we're going to start with you, Dr. Pope, because you're the only male.
Thanks.
So tell me, what made you want to become a surgeon? When did you decide that you were going to be a doctor?
I wanted to be a doctor from the time I was about 6 years old.
Really?
Yeah, it was either that or I really hadn't thought about anything else. I thought about teaching, I thought about doing all kinds of other different things. I did a lot of odd jobs through college and things like that, but it kept coming back to medicine.
Awesome.
And surgery kind of came in when I was around 10, and I had to have surgery myself.
Oh.
And then I started to think more and more about doing that because I wasn't extremely happy with the way the process went.
Oh, okay. So you thought, I'm going to become a surgeon, I'm going to do things better for the other 10-year-old little boy?
I don't know if it's I wouldn't necessarily say better, but maybe different.
Different, okay. So where did you grow up? Where are you from?
I grew up in Northeast Ohio, not too far from Lake Erie and Cleveland area.
Okay, okay. And you went to school where?
For medical school, I went to Lake Erie College of Osteopathic Medicine in Erie, Pennsylvania.
Gotcha.
And before that, I was at Youngstown State.
Okay. I'm trying to picture Erie in my brain. Is that near, what's that big falls? Niagara Falls? Or no, it's not. Sort of?
Hour and a half.
Okay.
It's a little bit further than that because you got to go all the way through New York to get up to Niagara Falls.
Okay.
I think that's actually Lake Huron,
Oh, okay.
where the Niagara Falls are.
See, I'm
Not 100% sure though.
apparently I don't know
In
my
Ontario.
geography.
I think that's the other one that's up there.
All right, and Miss Karen, what about you? When did you decide you wanted to be a doctor?
I always thought about becoming a physician. My dad was a dentist, so the idea of working in healthcare was always fascinating to me. And both of my sisters became dentists, so I didn't want to be a dentist. So I decided to go to medical school and become a physician.
Awesome. And where did you grow up?
I grew up about an hour northwest of Philadelphia, a little south of Allentown. And then I did a 5-year entry-level master's program at the University of Scranton in physical therapy. And then I went to medical school.
So is that why you're a DO, because you got physical therapy in your blood?
Yes, absolutely. It's a very good segue into DO school.
Yeah, we have a DO in our office, and she has been known to get down on the floor and adjust somebody in the office. So, you know, that she's really funny. I hope you get to meet her sometime. She wasn't there when you came to our office before. So, all right. So I bet you all met in college or in medical school.
We were set up on a blind date.
Really? Oh, tell us about that.
We were both on rotation. I was down in Florida with a mutual friend, and she said, I know this guy and he'd be the perfect guy for you. And she is the type of person, if she'd see 5 movies in one evening, they'd all be the best movie she's ever seen in her whole entire life. So she said, well, I'll set you guys up anyway. So we met and we've been together ever since.
So you were in Florida and he was in
Ohio.
In Ohio.
Well, that's a little tough to be dating, isn't it? You just Skype?
We did for a little while.
Well, that was actually before Skype.
Yeah.
Okay, now
Yeah.
now you're dating yourself
Yeah.
a little bit.
So
Okay.
we started with emailing and we met.
Sure.
And,
Awesome.
Had really large phone bills.
yeah, really large phone bills.
That was before you could have all your long distance on your
Exactly.
cell phones. You only got so many minutes and
Yep.
all that. Yeah. So that's what happens. But well, anyway, so had you practiced anywhere before you came to Rocky Mount?
I started in Michigan, my training, and I did some training on Long Island and training in New Jersey before coming down here.
Okay. So what made you go into plastic surgery? How did you segue from physical therapy to?
My mom was burned when she was 3,
Oh.
and she had to undergo reconstructive surgery along the way, so that kind of made me want to help other people.
I think that's awesome. Not that your mom got burned, of
Right.
course, but that, the events in our lives as kids can really start making a path for where we're to go. So I knew from a little girl I was going to be a nurse. I'm just, I knew that. Then there was this awesome show called Emergency with Julie somebody, I can't even remember who was on it. It was a long time ago. And I said, I'm going to be an ER nurse just like her. And I was. I worked in the ER at Nash General for 13 years and was at the hospital for 23 years.
Wow.
And then I said, I don't want to be here anymore. What am I going to do? So I threw my hat in to get into school, and I got in. It was a miracle. Anyway, so let's start with Karen, we'll go. So what are some of the options for reconstructive surgery?
There are 2 main categories. You have autologous, meaning using tissue from your body, or alloplastic or implant-based. So either a tissue expander followed by a permanent implant. So those are your 2 main categories. And there's different breakdowns of using your own tissue. You can use it from your belly, you can use it from your back. Some people are actually using it from their butt.
From my belly.
So, and then with the alloplastic or the implant-based, we can either, depending on the size of the breast, we can put a tissue expander in and increase the size of the breast if someone wants larger breast after mastectomy. Or if they're about the size that we want, we can actually put in the permanent implant right after the mastectomy is complete.
And how does the patient make that decision? I mean, I think I just want it all gone. I think that scares me, but
Right.
that's just me. So how do patients decide? I guess it's just individual.
It's very individual. First, it starts with a breast surgeon because they're the ones that actually discuss the mastectomy and the initial breast surgery with the patient. So it starts there.
Okay.
And then once they decide whether or not they need a mastectomy, if they do, then they come to me to talk about their reconstructive options.
Okay, so
And
go ahead.
I discuss with them their goals and what they want. Depending on the procedure, will change the amount of recovery needed. So we discuss what they want and what their desired visual outcomes are as well, whether they want similar looking, more natural breasts, or if they want something a little more perky, or what they want, and then that kind of shapes the conversation.
Awesome. So I send somebody to the breast care center, and then they tell me she has a suspicious lesion and we have to do a biopsy. Do you do those, or does the breast care
I usually
center?
have the radiologist do them.
Okay.
Depending on what's going on. I didn't do many of those during my training. I know some surgeons do their own biopsies, but I prefer to let the radiologist do it because they can get it done right then and there. They
Right.
don't have to wait and delay care. If they know they need a biopsy, they can just do it.
Right. And so it comes back positive, and so then I refer my patient to you first, right?
Correct.
And you were going to do what
So-
needs to be done.
With that, they come in and they talk to me, and I go through everything, and it goes in one ear and out the other. When someone
To the
tells you
patient,
you
you
have
mean?
cancer,
Uh-huh.
they are not able to create new memories. They can't remember it. So I always have them bring somebody with them
Yes.
Most times when people come in the first time and they don't have someone with them, I tell them, you're going to come back to me in a week. And I want you to get a notebook. I want you to write down all the questions that come up and keep that notebook with you at all times, because the questions are going to come at 2 o'clock in the morning when no one's there and you're not going to remember them. So write them all down and bring your family with you so that we can go over everything again. So I go through everything with them once and then go through it with them again, because they're not going to remember it the first time.
Right. All they can hear and think about is
that
cancer.
I have cancer and I'm going to die. And that's not necessarily the case.
No, I know it isn't, but it sure makes you think that way, that's for sure. So once they have had either a lumpectomy or a total mastectomy, I guess that is based on...
It's based on a few different things. It's based on the size of the tumor compared to the size of the breast. If you have a small tumor in a large breast, you can get away with a lumpectomy. If you have a large tumor in a small breast, you're probably not going to be able to get away with that and do breast conservation. One, because of the deformity, and two, because if we have to remove all the breast tissue, that's basically a mastectomy anyway. So it's a conversation that I go over the options with them. I don't ever tell anyone what they have to have done. I just tell them, this is what the options are. Based on what you have, I would suggest this or this, but it's up to them to decide.
Okay, and so then they have the mastectomy, I guess, we'll say?
Well, what we do is we have the conversation, and I encourage them to think about what they want to do, and then I refer them to see Dr. Szymanski so that they can have a discussion and decide what they think is best for them, because it's not my breast that's being removed, and everybody is individual about what they want and what their hopes and what their dreams are, and all those things. So I practiced in New York before I came down here, and it was actually a state law that if you were going to operate on a woman's breast, you had to give them the option to see a plastic surgeon as well.
Really?
Yes. So I started doing that then, and I continue to do it now, because there is a huge psychological impact on someone when you're removing their breast. There's a lot of stress on sexuality, femininity with the breast. So when you're removing that, you don't know how it's going to affect you. So I encourage them to have a discussion, to consider reconstruction if they do want to have the entire breast removed. So that's the next step. And then they go see her, and then they come back and see me, and we discuss what our plans are for the surgery, because sometimes after they meet her, their plans change.
Oh, okay. So you give your input, and then, so there's really a lot of steps in all this. It's not a matter of, oh, I got cancer, take it out, get plastic surgery, and boom, I'm ready.
Right.
It's not like that at all.
It's very dynamic, and it like Jason said, is he's had some patients that originally saw him, wanted a mastectomy, wanted to be done. And then he said, well, go see her, talk to her, because they hear of these horror stories. Oh, my friend was in the hospital for a week or two after. She's having still all of this pain 3-4 years later. I don't want to go through that. And breast reconstruction, like so much in medicine, continues to evolve and change. So the outcomes also evolve and change.
Right. Well, all right, it's time for our first break. So we will be back in just a minute with more of Here's to Your Good Health with Dr. Karen Szymanski and Dr. Ronald Pope. So don't go away, we'll be right back.
At Down East Hearing Care Associates, we are dedicated to taking care of every client by providing personal, high-quality hearing care services. My staff and I know hearing loss affects each person and their loved ones differently, so we give you the time and the care you need to ensure the hearing technology chosen fits your lifestyle. At Down East Hearing Care, we also make custom ear molds and specialize in emergency hearing aid repairs. Down East Hearing Care Associates has 2 locations, one in Knightdale and one in Rocky Mount. We have hearing lives to save.
Hi, I'm Richard Koss, pharmacist and owner of Almonds Drug Store here in Rocky Mount. Here today with my wife and 2 daughters. For over 75 years, Almonds Drug Store has been the pharmacy of choice for residents of Edgecombe and Nash County. Our family is proud to call Rocky Mount home, and we are excited about the new services and products we are adding daily at both of our Almonds Drug Store's locations and also at our medical supply store.
Come in and see us at Alma's Medical Supply. We're an extension of Almonds Drug Stores, your local hometown pharmacy. We're here to service all your needs, from wheelchairs to walkers to orthopedic supports to compression hose to hard-to-find wound care supplies. And you'll always get that hometown customer service.
We want our patients to pay the best prices, get the best service available, and have a better pharmacy experience than they will get anywhere else. Our staff is committed to going above and beyond to meet our patients' needs. Whether it is working with your provider to get you the best medication at the best price, contacting your provider to get you refills or a prior authorization, or taking the time to review each of your medications with you personally, or perhaps even helping you find an old-time remedy or other hard-to-find items, your Almonds Drug Store staff will work hard to meet your pharmacy needs. At Almonds, we will deliver your prescriptions for free. Both of our stores have drive-through windows, we guarantee short wait times, and our pharmacists will come out to greet you personally and answer any questions you have. If you want to be met with a smiling face, or even want someone to greet you by name when you walk through the doors, we are the pharmacy for you.
Call Almonds Drugs today.
443-3138 or 446-0014.
Well, hello, welcome back. I'm Linda Prezioso. I'm a nurse practitioner at Rocky Mount Family Medical Center. And I'm here tonight with Karen Szymanski and Ronald Pope. They are husband and wife. They are a team that has been here about a year and a half. Boyce Willis Clinic brought them in, and we're so blessed to have them in this area. And so we've been talking about reconstructive surgery, and Karen is using some kind of a new approach that is not done around here much. Is that correct?
It's fairly new, mainstream. It's been in the university centers for about 5 years. More and more people are starting to use the approach that I started learning in fellowship. And basically, we used to think we had to place the implant underneath the pectoralis muscle, which is the chest muscle in the front of our body underneath our breast. And we're finding that we can actually put the implant on top of the muscle. And by doing that, we're decreasing the amount of pain the patient has. So we're actually able to do the mastectomy and the reconstruction and have the patient go home the same day.
Really?
Yes.
Wow.
So
That's awesome.
yes.
Yeah. So how much pain is involved with this particular way that you're talking about?
We've had some patients, our anesthesiologists perform what we call muscle blocks or nerve blocks, and basically they instill long-acting anesthetic into the area, and we've had a few patients that have not taken any narcotic medication after surgery.
Really?
Yes.
Wow, that is awesome, especially in
Yes.
this day of don't take narcotics.
Right.
Take one, you're going to be an addict.
Right, right. So
I'm being a little facetious, sorry.
but it's true, and that's why we've
People
adopted.
do worry about it.
And
Of course we do.
Patients ask about it.
Absolutely.
So,
And we should worry about it. I
Right.
didn't mean to be so flip.
Nah. And we don't even send people home on narcotics any longer. We use a non-narcotic opioid instead of using narcotics, and that's been controlling our patients' pain by doing this type of technique, because we're no longer cutting the muscle,
Right.
which is extremely painful.
Yes.
So, and in addition to that, pain initially postoperatively, they also have long-term postoperative pain, because anytime you move your arms, your implants are going
Sure.
like this, which also not only is painful, some people don't like how it actually looks underneath their clothing.
Right. Wow. So you've got some implants here. Do you want to tell us about those?
Sure. So the one on my right is what we call a tissue expander. So for patients who are small-breasted, who want larger breasts, or I am lucky because my breast surgeon gives me good breast flaps. So my skin flaps are very thick, but there are some people who don't
do
give
not,
such good
yes,
breast flaps.
yes.
And we put these in to allow the breast flaps time to heal before we switch them to the permanent implant, which is on my left. So this allows us to expand the mastectomy flap slowly, so they maintain good blood supply, and then later we switch it out for the permanent implant.
So how long do you wear that expander on an average?
Average, usually 3 to 4 months. Each
Okay.
patient expands a little differently. And the other thing is, since I put the implant on top of the muscle, expansion also has decreased in pain because we don't have to stretch the
So
muscle.
I've heard that that's painful.
Absolutely, when you stretch the muscle, it's
Sure,
going to hurt.
sure.
With placing the implant on top of the muscle, you lose that pain. So you're actually able to stretch the patients quicker.
Wow. Fascinating. So I was just going to talk to Dr. Pope a minute about the BRCA 1 and 2. And I've got a reason for that because I've got a dear friend whose mom passed away. She was the oldest of 6. And I think Nina was a junior at Chapel Hill when Mom died. And so she became a nurse, took all of her siblings in. The boys decided they didn't want to live with their big sister, and they went to live with an uncle. But she had all the girls, and then one girl developed, the baby of the family developed breast cancer, and one of the boys developed prostate cancer. So I want to talk about that a little bit because it's kind of near and dear to my heart.
Absolutely. You can understand why. So BRCA is breast cancer. It's a gene. They're the 2 main genes that we know about. There are, at most recent count, there are 72 genes that have been expressed in breast cancers. But these are the 2 that we've known the most about for the longest, and they do have a very, very high correlation of being prone to develop breast cancer in your lifetime if you have one of these genes. And it's a gene that can be passed from mother to daughter, or father to son, or father to daughter and mother to son. So it's something that if you do have a breast cancer, or you're diagnosed early, or you have a strong family history, I strongly encourage people to get checked to see if they are a carrier for these genes, because again, if you have these genes, early detection, early therapy can be life-saving.
Sure. Do they test for those genes at the breast care center, do you know?
They can,
Okay.
but then we usually go through the process of, finding out about the risk factors, going through something called the Gale model, in which we assess a bunch of different factors to tell us if you're at high risk, low risk, or medium risk, to see whether or not we should proceed with that. Because the majority of cancers still are what we call point mutations. There's a little switch that goes off when you're changing your DNA that isn't supposed to be there, and then that causes it to keep propagating down the line so that you develop that cell into a cancer cell.
Right.
That's still the majority of cancers. These are much less frequent, but they do still happen.
Right.
So it's more younger patients around age 40 or younger. We definitely want to test them.
Right.
People who have every aunt and grandmother and everybody else in their family who has had breast cancer, they should definitely be checked.
Right.
And the people who have had the cancer should be checked as well, because if you know that you have it, then you can pass that information on to your
Right.
children as well and make sure
Right.
that they get tested
Right.
earlier.
Right. So my friend, she was not tested positive, but her brother that has the prostate cancer was. And of course her baby sister was. And then there was twin girls, and I don't think they did, but they all got double mastectomies and they all had hysterectomies. They'd already, been married, had
Right.
children, had done that part of their life, and so they just wanted to be proactive. Do you see a lot of that?
I've seen a few, especially after Angelina Jolie came out and started talking to everybody about hers, but it's become less and less now. I mean, it depends. With the BRCA2, we do see people who go and get the hysterectomy and then want to have bilateral mastectomies. Again, it dramatically decreases your risk. There is never going to be a risk of 0. But we do everything that we can to dramatically decrease the risk by offering those prophylactic mastectomies in those cases, yes.
That's awesome. All right, so what about lymph nodes? We still have cancer in the lymph nodes. You still test for that when?
Yes.
Yes.
That's-
Now, we don't necessarily do the full lymph node dissection like we used to. I do sentinel lymph nodes, and I usually take anywhere between 1 and 3 lymph nodes on each side. If there's cancer on both sides, I take samples of lymph nodes from both sides. I do not do the full axillary dissection because the full axillary dissection does tend to lead to the potential for development of lymphedema. And
Yes.
lymphedema can lead to a secondary cancer called lymphangiosarcoma.
Oh, I
So
didn't know that.
we try not to do that, and the newer research is showing that sentinel lymph nodes is enough. If a sentinel lymph node is positive, the patient is still going to require chemotherapy. So why would you go and add increased morbidity?
Right, right.
Whereas you can have that area radiated, which has less lymphedema than it does if you remove all the lymph nodes. So that's what we're tending to lean more towards at this point, is
That's
referring people
awesome.
to irradiation as
Yeah,
opposed to removing all the
yeah.
lymph nodes.
Because removing all those lymph nodes is really rough on this woman.
Extremely painful, absolutely.
And they still suffer years
Yes.
afterwards.
Yes, they do.
And so, then that's when the opiate problem comes in. So that can really be something. So now let's just talk a minute about breast reduction, because I have a lot of patients that, they get the grooves in their shoulders
Yes.
from the heavy breasts.
Yes.
And I've got a friend who's a physical therapist, and she'll do a lot of physical therapy with them to try help them. So is that being paid for by insurances, or is it an individual insurance company?
It's an individual insurance company. I'm fortunate to have an excellent office manager who's kind of compiled all of the information.
Oh, great.
So depending on the insurance, she knows what boxes need to be checked before we send it in, because
Yeah.
it is far easier to compile everything
Than
and
to
send it
try
in
to
than
fix
to
it
try
later.
to fix a denial.
Yeah.
So it can be a little lengthy process, and I'm sure is very frustrating for many patients who have pain. But having everything correct before we submit it is
Right.
a lot less painful than trying to overturn a denial. So, like you mentioned, your friend with the physical therapy, usually that's one of the things that's required by many insurance is physical therapy prior to ensure that the patient is ergonomically, performing all of their activities correct. So maintaining good posture, sleeping properly, lifting properly, in addition to making sure they're wearing the correct raw size and support that way.
Right.
And usually some women, because of the large breasts, develop infections underneath their breasts, so documentation of that is also important for some companies, that if you have recurrent infections underneath the breast that require over-the-counter or prescription medication, and it continues to recur, the insurance companies look on that as a confounding factor to cover breast reduction as well.
Okay, so you, of course, do that as well.
Yes.
Yes, of course.
Yes.
Silly me.
Right. Well, and they actually have found in some studies that you're decreasing the amount of breast tissue, there is actually a decreased risk of breast cancer in some people who actually undergo breast reduction surgery.
Oh, really?
Yes.
Yeah, I don't know why God formed some of those poor women with those large breasts, but I mean, it's tough. It's
Yes.
tough. So, this is a good question. Will I lose my nipples if I have bilateral mastectomies or a mastectomy?
It depends.
Sorry, guys, I'm sorry.
It depends. It depends on a couple of different factors. It depends sometimes on the cancer type, and it depends on the cancer location and its proximity to the nipple. So if you have a cancer that's right behind the nipple, yeah, unfortunately that nipple is going to have to come out. But if it's out in the upper outer quadrant or down the lower outer quadrant, and it's a safe enough distance away from the nipple, and we always check on an MRI to see if there's any potential invasion into the nipple, then there is the potential, yes, to do what's called a nipple-sparing mastectomy.
Nipple-sparing mastectomy, how about that? And then for those that have to have the the nipple removed, do they still do
Tattoos?
tattoos?
So we can do tattoos.
Do you do that too?
We haven't purchased a tattoo machine yet, but
Okay.
possibly thinking of it. But some of the tattoo artists do amazing 3D tattoos now that visually from a distance it actually looks like there's a mound. It's difficult to have that covered by insurance, but we try to work with some of the tattoo artists to see if they'll at least give the patient a reduction of fee, because it's not necessarily just for fun, it's
No, right.
for reconstruction.
Right.
But if they don't want a tattoo, we can actually use a skin graft from the inner thigh, which is a darker color, and that actually provides a tune tone
Really?
for the nipple. In addition to, we basically can I call it origami for the nipple, but we basically make a special cuts, we rearrange it, and we're actually able to create a nipple mount.
Awesome. I never, I mean, that's why I love this show, because I learn so much. This is all like news to me. I just say, well, you got to go see Dr. Szymanski, and then I'm done, and I move on to the next sinusitis or UTI. So, all right, how are we doing time-wise, Lee? We doing okay? Okay. Let's see, we talked about the tissue expanders and the silicone implants. And how about the old silicone implants that leaked and they have to be removed? Do you do that?
I do that.
You do that.
And
Is this silicone as well?
That's silicone. I think that's one of the older models. But the newer models, this is to at least provide a patient with an idea of size, volume, and what it feels like.
It's not the real thing.
It's an older one.
Okay.
The newer ones they call gummy bear, because you can actually cut it like a gummy bear and it has two halves, versus the old ones, if you'd cut it in half, I say it's more like a jelly donut. You cut it and it kind of squeezes out. So the new ones, when there is an actual rupture, it's not the leakage of the old silicone, similar to leaking out of the jelly donut if you would squeeze that.
Okay. All right, so let's jump over to Dr. Pope for a minute. And he is not only does he work with his wife for breast reconstruction, but he is a general surgeon, so he can take out your gallbladder or your appendix or do some colon surgery. Is that right? So, so if you go to the gastroenterologist and they discover a tumor in your colon, then they refer that person to you?
I would hope so.
I mean, they don't do it themselves.
Well, I mean, it depends on the size of the polyp. If it's a small polyp, sometimes the GI guys are able to do a polypectomy to remove the whole thing. Typically, they will tattoo it just in case it comes back as cancer, so that if we do have to do any additional surgery, I can find it from the outside. I do colonoscopies and EGDs as well.
Do you?
I do.
As a general surgeon,
It's required now in general surgery training.
Really?
You have to do upper and lower endoscopies. That's correct. You have to do a certain number of them, and I did a lot.
and they actually, he did more than the GI fellows that graduated.
I did, but and I enjoy them, and they're very good cases. And the majority of them you don't find anything, but if you do find something, again, you want to try and tattoo it so that you can find it later.
Right.
Because the goal is not to have to go in and try and feel for it.
Right.
Try to do it through smaller incisions, either laparoscopically or robotically, because people tend to heal quicker from a smaller incision than they do from larger incisions.
Right. So, do they still only have one robotic arm over at Nash, or they
Currently,
got another
there is
one?
still only one robot.
So it's still kind of limited in how many you can do in a day.
It
you
is.
get a slotted time.
We share. Myself, the OBGYNs, there's a couple other general surgeons as well as the urologists. We all kind of share it. And sometimes, there are certain instances where we do combine cases where there's a problem with the urologic or gynecologic, and so we can do things together in that aspect as well.
Do you like the robotic arm? Do you
I think that it works very well for certain things.
Not everything, huh?
I wouldn't use it to work on the breast. I wouldn't use it to work on the thyroid or anything else like that, but it is very effective for getting very low cancers in the pelvis. It's a very narrow area, and it's very hard to get instruments or your hands down into a very tight space like that. And it gives you the ability to do that through smaller incisions, quicker healing time, and a lot less pain than it would be to have to do it the old-fashioned way.
Right.
And it gives you the 3D visualization
It really does.
as well.
It's almost like being able to stick your head and your hands inside of a person to be able to do the surgery. It really, truly is an amazing technology.
So they do gallbladders, hernias,
Yep.
appendix?
You can do an appendix, but it's kind of a
'Cause that
high
lot-
expense to be able to do an appendix. Appendix is most often treated through laparoscopy or an old-fashioned open incision, and a lot of people are even treating people with appendicitis just with antibiotics. I'm not a big fan of that. I've had too many patients who have had
Yeah, I wouldn't.
complications from
I want it
afterwards.
out.
I think that if you have appendicitis, it should come out.
Yeah, I agree with you.
But you
there.
can also do it through one incision.
Correct.
Okay.
I have done the appendectomies through one small laparoscopic incision.
Golly, this is fascinating. All right, so is there any kind of hormonal therapy that has to be done either before or after the cancer, the breast
can be.
reduction?
When you send your patients and they get the biopsy, they always do special stains on that biopsy to see if they have receptors on the cells. Those receptors stimulate the cell to grow. So if they're there, that means that those cancer cells are stimulated by hormones that your body makes, whether it's estrogen, progesterone, or there's a medication that we call Herceptin. That's the other type of receptor that they look for. If those receptors are positive, that means that those receptors are present on the cell. You can give a medication that blocks those receptors so that it can help to reduce the cancer. And we do sometimes do that for certain patients depending on the stage that they are in, if they have positive lymph nodes or if they have a very large tumor, or if we're concerned that they have metastasis. We're going to treat them with what we call neoadjuvant therapy first. So they get treated with chemotherapy or with hormone suppression therapy to try and shrink the tumor before we do surgery, or to regress it back so that it doesn't have metastasis or too many involved lymph nodes.
Okay, awesome. So Karen, I'm going to ask you some personal things about me, not you.
Okay.
Because I've got these great marionette lines right here. Has nothing to do with how old I am, of course. It's the stress of the job.
Absolutely.
It's the constant smiling in the job.
that too, content
So, really, but, so do you do some of the facial things? I mean, like if somebody wants their lips
Yes.
enlarged, you do that
Yes.
too? Okay.
Yes,
Is that done in the office? Or?
Yes.
Okay.
So actually, during my training, I was lucky to learn from a gentleman who did nearly everything in his office under local anesthetic as well as oral sedation. So I do from your eyelids to your upper eyelids, your lower eyelids, facelift, all under local anesthetic with some oral sedation. In addition to basic skin cancers that I treat in the office, just under local, and then fat grafting is kind of the newer thing that people are starting to jump on the bandwagon. That I remember learning about it or watching it on Sex and the City, where Samantha goes to the plastic surgeon. She's like, I can take fat from my butt and put it in my face. So, and it's becoming a lot more mainstream just because of the different ways we can process fat so quickly. So we're able to use it instead of hyaluronic acid fillers like Juvederm. We can actually use fat to basically augment the cheekbones, and by augmenting the cheekbones, you're lifting the entire face.
Right.
And in addition, the fat actually brings stem cells, and the stem cells help to rejuvenate your skin from the inside.
Really?
Yes,
Well, that's pretty cool.
very cool.
Yeah.
And that can all
So-
be done in the office, just
And-
under local.
But is all that like considered cosmetic for the most part?
For the most part, it is.
Regarding insurance? I mean.
Correct. The only time it's not is in training. I worked at a craniofacial birth defect center.
Oh, yeah.
So we used a lot of fat grafting and autografts for the children to improve their contours.
Wow, that's awesome. That is awesome.
Yes.
Well, I don't have enough money in my poor little checking account to go see about my marionette line, so we'll have to move on. So you did say, like, would you tattoo like the permanent like eyeliner? Is that something you do, or where does that get done if they want to do that?
There's some estheticians that
Do that?
do that, but we don't do that in my office.
Okay. I can't imagine tattooing my eye. I can't do it. I just can't do it. All right, we're going to take a break, and we'll be right back, and we'll be asking more questions of Karen and Ron to see what else we need to know about the fascinating surgeries that they do and how well they work together. So don't go away. We'll be right back.
At Nash, we believe the health of our community is paramount. That's why we're always growing and improving. Most recently, we added 3D mammograms to our breast care center to allow our breast imaging experts to more precisely diagnose the presence or absence of cancer. So mother, daughter, and grandmother can get on with life without the uncertainty of where they stand. Nash Healthcare and the women of our community at the heart of it all.
Hi, I'm Richard Koss, pharmacist and owner of Almonds Drug Store here in Rocky Mount. Here today with my wife and two daughters. For over 75 years, Almonds Drug Store has been the pharmacy of choice for residents of Edgecombe and Nash County. Our family is proud to call Rocky Mount home, and we are excited about the new services and products we are adding daily at both of our Almonds Drug Store's locations and also at our medical supply store.
Come in and see us at Almonds Medical Supply. We're an extension of Almonds Drug Stores, your local hometown pharmacy. We're here to service all your needs from wheelchairs to walkers to orthopedic supports to compression hose to hard-to-find wound care supplies. And you'll always get that hometown customer service.
We want our patients to pay the best prices, get the best service available, and have a better pharmacy experience than they will get anywhere else. Our staff is committed to going above and beyond to meet our patients' needs. Whether it is working with your provider to get you the best medication at the best price, contacting your provider to get you refills or a prior authorization, or taking the time to review each of your medications with you personally, or perhaps even helping you find an old-time remedy or other hard-to-find items, your Almonds Drug Store staff will work hard to meet your pharmacy needs. At Almonds, we will deliver your prescriptions for free. Both of our stores have drive-through windows, we guarantee short wait times, and our pharmacists will come out to greet you personally and answer any questions you have. If you want to be met with a smiling face, or even want someone to greet you by name when you walk through the doors, we are the pharmacy for you.
Call Almonds Drugs today.
443-3138 or 446-0014.
Well, welcome back. We are back here. This is Here's Your Good Health. My name is Linda Prezioso. I'm a nurse practitioner at Rocky Mount Family Medical Center. And tonight we have Dr. Ron Pope and Dr. Karen Szymanski, who are a husband and wife team that do a lot of reconstruction surgery together. They also have their own separate practices. They're in separate buildings. So we're going to just keep on talking about that. But before we go into any more procedures, Dr. Pope, tell me where you are. Where are you located? What are your hours?
My office is at 250 Nash Medical Arts Mall. We're in Suite A. We're just across from where the breast imaging center is, just behind the hospital. The hours, the office is open. I see patients from 8:30 to 5, depending on which day of the week it is. Some days I'm doing surgery, some days I'm in the office. And we're open Monday through Thursday from 8:30 to 5, and then from 8:30 till noon on Fridays.
Okay. And so do I have to refer my patients to you, or?
They do prefer that, yes.
Okay.
But it's not required.
But it's not required. I don't mind. I'll see anybody for any reason, but a lot of the insurance companies do want a referral.
Yeah.
But I have no problem seeing
I'd
anybody
rather just
regardless.
refer and have it all above board, so I
And
don't
so
have
would
to
I.
worry about that. All right, Dr. Karen, and you, where are you at?
I am across from the entrance to Candlewood in the new office buildings that I'm on the 45 Guardian Court Suite B, and it's right on, I share a building with the UNC neurosurgery office.
Okay, yeah, so I know where you are. You're right down on off
Correct.
Sunset. Okay. And what about, do I have to refer to you?
So
Or
similar.
it depends upon?
Depends upon the insurance. We accept any insurance, and if they can make a referral, that'd be great, but not all insurances require it.
Okay. So if I want to have a tummy tuck, I can just call you and say, I need a tummy tuck.
Yes, we actually have to call Megan. She manages all my patients in the office,
Okay.
but she's very good at fitting everyone into my
Okay,
schedule.
okay. And so what's the there's a liposuction versus tummy tuck. Which is which?
Liposuction is for people who are at a body weight that they're happy with and just need to lose a little extra from their sides or their belly, versus a tummy tuck is for people who have extra skin and extra fat who need both removed, or if they've had massive weight loss surgery like bariatric surgery and they've lost a lot of weight, some of those patients have excess skin and fat that need to be removed as well.
Gotcha. Okay. So is liposuction dangerous or no?
For the most part, liposuction's fairly well-tolerated procedure with minor complications. There have been reported incidents of people who have injured intestines when they've done liposuction, but for the most part, the majority of people have some swelling. Seromas are the most common, as well as some bruising.
Okay. All right. And what about eyelid surgery? What's that called? Is it called ptosis, when your eyelids cover up your eyes?
Dermatoclasia.
There you go. That's why I have these intelligent folks here, and I just say, I think it's this. Go ahead. Tell me what that's all about.
So for some people, it's actually covered by insurance. We see them document some measurements, and then we have them see their eye doctor, who does a few other measurements. Like we kind of talked about before, having your T's crossed and your I's dotted before you submit everything to insurance makes the approval process that much easier.
Okay.
So again, Megan created these forms that she goes over with the patients, that depending on the insurance, what they need to do in order to ensure we have all the documentation needed for insurance approval.
Okay.
And then people who don't meet insurance approval can still have their eyelids done. It would just be considered cosmetic. And we can still do that in the office under local. Some people just want it under local. Some people want some Valium to kind of help them relax before we put the local in. And then some people still want to go to the hospital and be under general anesthetic.
I'm the baby. Get me knocked out. Although I just had this cataract removed, and I don't really remember a lot of it, but I remember Dr. Robertson saying, look up, Linda, look to the right, look to the left. And I guess I did it because I can see better now.
There
So
you go.
anyway, let's see. So Botox, do you use Botox in your practice?
Yes, we use Botox for the normal wrinkles. Most people complain about the wrinkles between their eyebrows, and the other major one is their forehead, and the last would be their crow's feet.
Crow's feet.
Yes.
We all got crow's feet.
Right.
Don't we?
And then we also do it for migraines, but it is getting more and more difficult for insurance coverage for it. So we have Botox patients that have migraines that have a lot of benefits, and they feel they just pay for it because they want it done because it helps their migraines and don't want to wait for insurance approval.
I knew that you used, and you do the Botox for migraines as well?
Yes.
Well, you just got your fingers in a little bit of everything. That's awesome.
Yes.
It's like my office. It's a one-stop shop. We're just like the Walmart.
Yep.
All right, and now Dr. Pope was telling me about Botox in a little bit more delicate body parts. I'm going to let him talk about that.
Yeah, that's a whole other area.
It's the other side.
Yeah. She's got the heads, I get the tails.
Exactly.
So there is a thing called a pharmacologic sphincterotomy. Now that's a really big, long word that means that we use Botox for something called an anal fissure. An anal fissure is a small tear for people who have chronic constipation and things like that that can be very, very painful and cause spotting of bleeding and pressure and other uncomfortable sensations throughout their day. The old treatment was you'd have to go in and cut the muscle, which can lead to incontinence or the inability to retain stool or air.
Nice.
And that's never a fun thing. With Botox, the chances of that happening are much, much less. And if it does happen, it's usually only temporary because Botox only lasts 3 to 6 months.
It does. I thought they'd fix that somehow. I guess not.
Nope.
So
Unfortunately.
we have had very good success with it. The average rates are 1 to 3 treatments are needed, depending on what the symptoms are and how severe it is.
So do you do that in the office?
I do not, because that's such a sensitive area. I would, if it was me, I would want to be asleep, so I offer that to my patients. So I
Okay.
typically do that in the operating room.
Okay.
But it's a very short procedure. It's just, you go in, you get knocked out, so you don't feel anything. I inject the Botox, and then we wake you up.
And is it real painful when you wake up, or?
Typically, it's not, because I don't inject it into the outside where all the sensation is, but I have to spread things gently to be able to get to the inside to be able to inject it.
Gotcha, gotcha. Fascinating. So, let's see. How about working out? What does that do as far as?
So there's a lot of information that's been coming out recently about being physically active and how much benefit there is to your health. Physical activity has been shown to decrease your potential risk for developing cancer. There's even a study that came out about 9 months ago that showed that with women who have had breast cancer, who exercise 1 hour a day, 3 to 5 days a week, can decrease their rate of recurrence by 30 to 50%.
Really? That's a high
huge.
number.
It's huge.
Yes.
So, and all it takes is getting up and going to the gym, going for a walk, walking a couple miles,
Right.
3 to 5 days a
Right,
week. That's
right.
all it takes. And it decreases your risk of cancer. We're seeing an uptick in pancreatic cancer. We're seeing upticks in most types of cancer because most people have very long, very grueling jobs that they spend sitting, and they aren't able to be physically active. We're meant to be physically active. We're meant to be up and
Oh
moving
yeah, we were
around.
built, God built us to move.
And when we don't, it has bad effects on the body.
Yes, yes.
But when we do, it can be preventative.
Yeah, that's awesome. I'm glad you mentioned pancreatic cancer. You know, it used to be a death sentence, and do they still do Whipples?
They still do Whipples.
So they actually do them robotically now.
Really?
I don't do them.
You
but
don't?
People do them.
You want
I
to
don't
actually
think anybody here in town does.
No one here in town does that I'm aware of. I think that people have done them in the past, but typically people are referring them to bigger centers because if it was you or me or someone in our families, we'd want them to go to someone who does them all the time.
That's exactly right. That's exactly right.
Well, and they show better outcomes if you're done at a high volume institution. And it's interesting because when you look at the research, it's not necessarily that the surgeon themselves is doing high volume, it's the actual post-operative care that is important in the recovery process
All
after
those
pancreatic
wonderful nurses
surgeries.
on the floor and everybody else that helps everybody out, that really does make a big difference.
Yeah. And then do they go to to like rehab afterwards, like you do for, I don't know, I'm asking.
They can.
They can.
It's there's a lot of factors that are involved. You know, you have to learn how to eat again. You have to make sure you're taking supplements again. I mean, it's a long, drawn-out process. The recovery time is anywhere to 6 to 8 weeks, but it doesn't necessarily mean that you have to be in the hospital that time or in a rehab center that time. It's just recovering from everything and adjusting to your body being different.
Right, right. So when they do a Whipple, how much of the pancreas do they take out?
Depends on where the tumor is. If it's in the head of the pancreas, sometimes they're able to preserve the back half or the tail of the pancreas and reattach that. Other times, depending on how large the tumor is or whether it's invading into other structures, sometimes they won't even do the procedure. They'll just treat with chemotherapy to try and shrink it. If it's involving the blood vessels, it's not an operative candidate, and the only treatment is chemotherapy.
Yeah. So it really depends upon where and how big and what it's affecting before.
Correct.
You can, because it used to be, he's got pancreatic cancer, well, kiss him goodbye, but it's not.
The treatments really have done, the people doing the research are amazing. They're really coming up with new spins on the old treatment programs and new regimens, and it's really, people have a good chance for having a decent survival now. 5-year survival is not 0 anymore.
Right.
It's gone up to about 30% for
Yeah.
most people in early stage 1 and 2 cancers.
And I believe it's the same for lung cancer, that is much more survivable now than
Correct.
it was even a few years ago, which makes my heart happy because the nurse that I worked with in the ER, she's got stage 4. And
That's
it
no
breaks
fun.
my heart. No, no. All right, well, we're going to be done here in just a minute. So is there anything you want to tell our audience about coming to see you or things they should look for, and either one of you?
I know one thing that we do see a lot of is skin cancer, so I think
Oh,
it's
yeah, we
really
didn't touch
important
upon that.
that people, take it seriously. I actually, in my training program, had a gentleman that had squamous cell cancer that got so bad that it evaded invaded from his skin through his skull into his brain. So luckily we were able to resect it, but we had to actually resect part of his bone of his skull and actually use part of his muscle to cover that.
Oh my
So
gosh.
making sure you are wearing a hat, you are wearing sunscreen, and you are reapplying that sunscreen on a regular basis, and wearing long sleeve shirts and making sure that you're putting it on your arms and legs.
And your children.
And your children.
And I'm a sun worshiper. I'm the worst.
Oh, and oh yeah,
Well-
and also making sure you get your routine skin checks.
Yep.
I'll have to make an
Don't forget those
appointment.
dermatologists.
Yeah.
They're very important.
Exactly.
Yes. So you don't do the checks. You just do the removal.
Correct. I have some patients that have concerning lesions, and we both do actually, but I know that the dermatologists are very busy in the area, and
Yes,
sometimes
they
the
are.
patients can't get in, so
Yes.
they'll come to us and say, I have this lesion, and this lesion, and this lesion, and that lesion. And I said, well, if you have all these lesions, you really should be checked by the dermatologist.
Right.
But if I have the patient that says, this lesion's new and I can't see the dermatologist for a couple months, can we biopsy it? I'll biopsy it, or he'll
Okay.
biopsy it.
Okay.
So,
So you try to accommodate as much as possible.
yes,
We
both
do.
of us do.
Dr. Pope, you have anything else you want to say before we say goodnight?
Thanks for having us. This was a lot of fun.
You're welcome. Thanks
Yes.
so much for coming. I really appreciate it. We need to do it more often.
Absolutely.
So, all right, y'all. Thanks for watching, and we will see you next week with more of Here's to Your Good Health. Good night. Well, hello. Welcome. This is